related disorders. Obsessive-compulsive disorders, or OCD, are characterized by the presence of obsessions and/or compulsions. Obsessions can be described as recurrent and persistent thoughts, urges, or images that are experienced, and these are intrusive and unwanted and provide the individual with discomfort. Compulsions can be explained as repetitive behaviors or mental acts that an individual feels driven to perform in response to an obsession or according to rules that must be adhered to. Other obsessive-compulsive and related disorders are characterized primarily by recurrent, body-focused, repetitive behaviors, such as hair pulling or skin picking, and repeated attempts to decrease or to stop such behaviors. Our first disorder to discuss is obsessive-compulsive disorder, or OCD. Let us start with the categories of OCD. Most people with OCD fall into one of the following categories. Washers. They are afraid of contamination and they usually have cleaning or hand-washing compulsions. Checkers. These individuals continuously check things that they associate with harm or danger, such as checking that the doors are locked at night continuously, or that the oven is turned off continuously. Doubters and sinners. Individuals are afraid that if everything is not perfect or done just right, that something terrible may happen, or that they will be punished. Counters and arrangers. These individuals are obsessed with order and symmetry, and they may foster superstitions about certain numbers, colors, or arrangements. Let us have a look at common obsessive thoughts in OCD. These include the following: fear of germs or dirt in terms of being contaminated by it or contaminating others. Fear of losing control and doing harm to oneself or others. Intrusive sexual thoughts that may be violent. Excessive focus on religious or moral orientations or ideas. Fear of losing or not having the things that you may need, which may lead to hoarding. The obsessive need for order and symmetry, together with the idea that everything must line up just right. Obsessive superstitions, in terms of giving excessive attention to something that is considered lucky or unlucky. Let's focus our attention on common compulsive behaviors found in OCD. These include the following: excessive washing to control for being contaminated by germs or dirt. Repeated checking in on loved ones to make sure that they are safe. Counting, tapping, repeating certain words or partaking in other senseless rituals to reduce anxiety. Continuously ordering and arranging things to be sure that they are done just right. Praying excessively or engaging in rituals triggered by religious fear. Accumulating items that are not necessarily needed in the fear of, or fearing that one may not have the things one may need at a specific time in the future. Many theories have been developed to explain why OCD occurs. The main orientations for why the disorder develops include the following: brain functioning is different from those not suffering from OCD. Research findings suggest that OCD symptoms involve communication errors among different parts of the brain, including the orbitofrontal cortex, the anterior cingulate cortex, the striatum, and the thalamus. Abnormalities in the neurotransmitter systems. Chemicals such as serotonin, dopamine, glutamate, and others may be involved in the development of OCD. A combination of neurobiological factors, genetic, behavioral, cognitive, and environmental factors. Twin studies have revealed that genetics contributes approximately 45 to 65% of the risk for developing the disorder. Learning theorists posit that behavioral conditioning may play a role in the development and maintenance of obsessions and compulsions. These individuals may experience the anxiety of the obsessions and learn that the compulsions relieve them of the anxiety. Cognitive theorists believe that dysfunctional thinking is involved in developing OCD, specifically in terms of interpretation of intrusive thoughts that lead to the creation of obsessions and compulsions. Environmental factors may also have an impact on the development of OCD. Traumatic brain injuries have been associated with the onset of OCD symptoms, providing further evidence of a connection between brain function impairment and OCD. The Obsessive-Compulsive Cognitions Working Group, an international group of researchers, have identified and proposed 6 types of dysfunctional beliefs that are associated with OCD, including the following: inflated responsibility, having a belief that one can cause and is responsible for preventing negative outcomes. Overimportance of thoughts, the belief that having a bad or negative thought can influence the probability of the occurrence of a negative event, or that having a bad thought is morally equivalent to also doing it. Control of thoughts, the belief that it is both essential and possible to have total control over one's thoughts. Overestimation of threat, having the belief that negative events are very probable and that they'll be particularly negative. Perfectionism, harvesting the belief that one cannot make mistakes and that imperfection is unacceptable. Intolerance for uncertainty, a belief that it's essential and possible to know without a doubt that negative events will not happen. The DSM-5 includes 4 criteria for the diagnosis of OCD. For a person to be diagnosed with OCD, they will have to meet the following criteria. A. The presence of obsessions, compulsions, or both. Obsessions are defined by the following: recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. The individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action, for example, by performing a compulsion. Compulsions are defined by the following: repetitive behaviors, such as hand-washing, ordering, and checking, or mental acts, such as praying, counting, repeating words silently, that the individual feels driven to perform in response to an obsession or according to the rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are excessive. Let us finish the diagnostic criteria for OCD as per the DSM-5 with going through criteria B, C, and D. B. The obsessions or compulsions are time-consuming. For example, they may take more than 1 hour per day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. C. The obsessive-compulsive symptoms are not attributable to the physiological effects of a substance, such as a drug of abuse or a medication, or another medical condition. C. The disturbance is not better explained by the symptoms of another mental disorder. What are some of the associated features that support the diagnosis for OCD? Individuals often have symptoms in more than one domain or dimension, such as having obsessions with cleaning and symmetry, for example. OCD individuals generally experience a range of different emotional responses when situational triggers for obsessions and compulsions are experienced. Many individuals experience marked anxiety. Others report feelings of disgust and some complete feelings of incompleteness until the compulsion has been completed. Those with contamination obsessions may avoid public places such as restaurants and public restrooms to reduce the exposure to feared contaminants, and individuals with intrusive thoughts about causing harm to others may avoid social interactions or situations. Let us consider the functional consequences of OCD before we look at treatment options for the disorder. OCD is characterized by a reduced quality of life as well as high levels of social and occupational impairment. Impairment occurs across a variety of different domains of life and is associated with symptom severity. The greatest impairment of OCD is most likely the time spent obsessing over thoughts and acting on obsessions through compulsions. OCD patients often avoid situations that may trigger their obsessions, and this may restrict their functioning or areas of functioning. The most effective treatment for OCD is a type of cognitive behavior therapy, or CBT, called exposure and response prevention, or ERP, and along with SSRIs, it has been shown to be the most effective treatment for OCD. ERP is a type of behavioral therapy that exposes OCD sufferers to situations that provoke their obsessions, which will then lead them to experience the distress of the obsessions that usually lead to their compulsions. In ERP, response prevention is key, meaning that the therapist will help the OCD patient to not react to their obsessions with compulsions because it evokes even more anxiety in the long term, leading the brain to think that the only way to get rid of the obsessions is to react with compulsions. When patients do not turn to compulsions, they learn to accept their obsessions instead of acting desperately to neutralize them. When treatment has progressed for some time, the thoughts still seem difficult, but they no longer seem like a big problem. This process is called habituation. As patients undergo therapy and learn to habituate to the feelings their obsessions bring up and reduce their reliance on compulsions, they spend less time and energy avoiding the uncomfortable sensations that the obsessions present with. The SSRIs provide the brain with enough chemicals and feel-good hormones to work effectively together with the ERP. Students, this was obsessive-compulsive disorder. If you have any further questions on the disorder, you know where to find me. Let's move on to discuss body dysmorphic disorder. Students, remember, all the disorders that we are discussing today fall under the category of obsessive-compulsive types of disorders. This means that there are obsessions of some type involved in every disorder. Let me provide you with a brief introduction to body dysmorphic disorder. A lot of us have something about our physical appearance that we do not like, and although it may bother us sometimes, they generally do not interfere with our daily lives. However, people with body dysmorphic disorder or BDD think about their real or perceived flaws for hours each day. They are unable to control their negative thoughts and do not believe people when they tell them that they look just fine. Such continuous thoughts about their physical appearance may cause severe emotional distress and interfere with their daily functioning. They may miss school or work and even avoid social situations, isolating themselves, even from family and friends, for the fear of someone noticing their physical flaws. BDD affects about 1.7 to 2.4% of the general population, which accounts for approximately 1 in 50 people. BDD is a body image disorder and is characterized by persistent and intrusive preoccupations with an imagined or slight defect in one's appearance. Patients with BDD may dislike any part of their bodies, but they often find fault with their hair, skin, nose, chest, or stomach. In reality, the defects defined by BDD patients may only be slight imperfections, or sometimes they may even be non-existent. However, for a patient with BDD, the flaw is significant and prominent, causing the patient severe emotional distress and difficulties in daily functioning. BDD often also occurs in adolescents by the age of 12 to 13 years. The exact causes for BDD are unclear. However, certain biological and environmental factors, such as perfectionism, portrayed in the media, may contribute to its development. Genetic predispositions, neurobiological factors, such as malfunctioning of serotonin in the brain, personality traits such as neuroticism and perfectionism, and life experiences such as child maltreatment, sexual trauma, or peer abuse may also be contributing factors to developing BDD. The DSM-5 lists 4 criteria for the formal diagnosis of BDD. Let's go through them. Criterion A states that preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to others must be present. Criterion B states that at some point during the course of the disorder, the individual has performed repetitive behaviors, such as mirror checking, excessive grooming, skin picking, or reassurance seeking, or mental acts, such as comparing his or her appearance with that of others, in response to the appearance concerns. Criterion C states that the preoccupation causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. And finally, Criterion D states that the appearance preoccupation is not better explained by concerns with body fat or weight in an individual whose symptoms meet diagnostic criteria for an eating disorder. Let us consider the diagnostic features of body dysmorphic disorder. As mentioned, individuals with BDD are preoccupied with one or more perceived defects or flaws in their physical appearance, which they believe look ugly, unattractive, abnormal, or deformed. Oftentimes, the perceived flaws are not observable by others or appear only slight to other individuals. Concerns usually range from looking unattractive or not right to looking hideous or like a monster. Some individuals are concerned about perceived asymmetry of body areas, and their preoccupations are intrusive, unwanted, time-consuming, occurring on average between 3 to 8 hours each day. The preoccupations are usually difficult to resist or control, Individuals perform repetitive behaviors or mental acts in response to the preoccupation. The individual feels driven to perform these behaviors, which are not pleasurable, and it may increase anxiety and are often difficult to resist or control. The preoccupation must cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Let us go over some of the most common excessive or repetitive behaviors on the next two slides. Some of the excessive and repetitive behaviors in BDD include the following: to compare one's appearance with that of others, repeated checking the perceived defects in mirrors or other reflective surfaces, excessive grooming, camouflaging, seeking reassurance about how the perceived flaws look, and touching disliked areas to check them. The last 5 most common repetitive behaviors that BDD patients engage in include the following: excessive exercising or weightlifting, seeking cosmetic procedures, excessive or compulsive shopping, excessive sun exposure to compensate for pale skin, and repeated changing of clothes to cover for defects. Individuals with body dysmorphic disorder oftentimes have ideas or delusions of reference, believing that other people take special notice of them or mock them because of how they look. BDD is also associated with high levels of anxiety, social avoidance, depressed mood, neuroticism, and perfectionism, low extroversion, and low self-esteem. Although many BDD patients are ashamed of their appearance, others may seek out cosmetic procedures to try and improve their perceived defects. Dermatological treatment and surgery are the most common, but any type of treatment may be sought out. BDD seems to respond poorly to such treatment, and oftentimes symptoms become worse after such treatments. Some individuals take legal action or are violent towards the clinician after their surgeries because they are dissatisfied with the cosmetic procedure. Finally, BDD has been associated with executive dysfunction and visual processing abnormalities, with a bias for analyzing and encoding details rather than holistic or configural aspects of visual stimuli. Individuals with BDD further tend to have a bias for negative and threatening interpretations of facial expressions and ambiguous scenarios. Body dysmorphic disorder is treated the same as obsessive-compulsive disorder. Therapists use cognitive behavior therapy and specifically exposure and response prevention, together with SSRIs, to treat BDD. The SSRI that is most often prescribed for treating BDD is fluoxetine, also called Prozac. Fluoxetine is an antidepressant and is often also prescribed for obsessive-compulsive types of disorders and bulimia. Therapists using ERP will work to expose the patient to the area or areas of their bodies that they are unhappy with and teach them to allow the anxiety associated with it and not to give in to the compulsions of looking in the mirror, camouflaging, or engaging in any other compulsion for the obsession with a disliked body part to dissipate and the anxiety to lessen. Students, I hope you have found body dysmorphic disorder interesting. We will now move on with your lesson to address hoarding disorder. Individuals with hoarding disorder have difficulty discarding items because of the strong perceived need they feel to save such items, and they may experience intense distress when they have to discard items. Let me provide you with an introduction to hoarding disorder. Those suffering from hoarding disorder excessively save items that others oftentimes may view as worthless. They have great difficulties with getting rid of or parting with possessions, which lead to clutter that disrupts their ability to use their living or work spaces. Hoarding must not be confused with collecting items. Collectors look for specific items, such as antiques, model cars, or stamps, and they may organize and display them. Those with hoarding disorders save random items and store them haphazardly, and they often feel like they are saving such items for future use. The items that they save may or may not be valuable and may or may not have sentimental value. Some hoarders feel a sense of enhanced safety when they are surrounded by the things that they save. Hoarding disorder occurs in approximately 2% to 6% of the population. It is more common in males than in females, and it often leads to substantial distress and problems with functioning. The disorder is more common among older adults between the ages of 55 to 94 years compared to adults 34 to 44 years old. Individuals with hoarding disorder have difficulty with discarding items because of the strong perceived need they feel to save items and or the distress they experience when discarding items. The most common symptoms of hoarding disorder include the following: experiencing lasting problems with throwing out or giving away possessions regardless of their value. The problems are due to a perceived need to save the items and the stress associated with parting with the items. Saved items will fill, block, and clutter active living spaces so that such living spaces cannot be used, or use is hampered by a large number of items. The hoarding causes major distress or problems in social, occupational, or other areas of functioning, including maintaining a safe environment for the individual and others. The DSM-5 lists 6 criteria for the formal diagnosis of hoarding disorder. These include the following: A. Persistent difficulty discarding or parting with possessions regardless of their actual value. B. This difficulty is due to a perceived need to save the items and to distress associated with discarding them. C. The difficulty of discarding possessions results in the accumulation of possessions that congest and clutter active living areas and substantially compromises the intended use. If living areas are uncluttered, it is only because of the interventions of third parties. D. The hoarding causes clinically significant distress or impairment in social, occupational, or other areas of functioning, including maintaining a safe environment for self and others. E. The hoarding is not attributable to another medical condition, such as brain injury, cerebrovascular disease, or Prader-Willi syndrome. And F. The hoarding is not better explained by the symptoms of another mental disorder, such as obsessions in obsessive-compulsive disorder, decreased energy in major depressive disorder, delusions in schizophrenia, or another psychotic disorder. Students, let us continue with hoarding disorder. What are some of the additional diagnostic features of hoarding disorder? Let me provide you with the information. Hoarders experience persistent difficulties in discarding or parting with possessions, regardless of their actual value, indicating a long-standing difficulty rather than more transient life circumstances that may lead to excessive clutter, such as inheriting property or items. The difficulty in discarding refers to any form of discarding, including throwing away, selling, giving away, or recycling. The main reasons for experiencing difficulties in discarding items are the perceived utility or aesthetic value of the items or strong sentimental attachment to the possessions. Some hoarding disorder patients feel responsible for the fate of their possessions and will go to great lengths to avoid being wasteful. Also, fears of losing important information are common. The most commonly saved items are newspapers, magazines, old clothing bags, books, mail, and paperwork. However, any items can be saved. Many hoarding disorder patients also collect valuable items, and these are often found in piles or mixed up together with less valuable items. Individuals with hoarding disorder suffer from distress when faced with the possibility of having to discard items. Therefore, the saving of items is intentional, which discriminates hoarding disorder from other forms of psychopathology. Let us consider the associated features that support the diagnosis of hoarding disorder. Other features of patients suffering from hoarding disorder include indecisiveness, perfectionism, avoidance, procrastination, difficulty with planning and organizing tasks, and distractibility. Because of the clutter, some individuals with hoarding disorder may live in unsanitary conditions, which may be at the detriment of their health. Students, animal hoarding is viewed as a special manifestation of hoarding disorder. Animal hoarding can be defined as the accumulation of a large number of animals and a failure to provide the minimum standards of nutrition, sanitation, and veterinary care, and to act on the deteriorating condition of the animals and the environment. Most individuals who hoard animals also hoard inanimate objects. The most prominent differences between animal and object hoarding are the extent of unsanitary conditions and the poorer insight in terms of animal hoarding. The DSM-5 lists 3 risk factors for the development of hoarding disorder. These include temperament, environment, and genetics. What does the DSM-5 indicate in terms of temperament and hoarding? Indecisiveness is a prominent feature of individuals with hoarding disorder and their first-degree relatives. And this is a temperamental trait. In terms of the environment, individuals with hoarding disorder often report stressful and traumatic life events preceding the onset of the disorder or causing an exacerbation of minimal symptoms. Let us consider the hoarding patient's genetics. Hoarding behavior seems to be familial, with approximately 50% of individuals who display hoarding behavior having a relative who also hoards. Twin studies indicate that 50% of the variability in hoarding behavior is attributable to genetic factors. Students, before we look at treatment options for hoarding disorder, let us look at 7 functional consequences of hoarding disorder. These include the following. Clutter impairs basic activities such as moving around the house, cooking, cleaning, personal hygiene, and sometimes sleeping. Appliances may be broken. Utilities such as water and electricity may be disconnected, as access to repair work may be difficult. The quality of life for the hoarding individual is often impaired. In severe cases, hoarding can pose a risk of fire, poor sanitation, or falling, especially in the elderly. Family relationships are often under great strain because of the hoarding behavior. Conflict with local authorities, landlords, and neighbors is common. Some individuals with hoarding disorder have been involved in legal eviction proceedings, and some have a history of eviction. Hoarding disorder is not easily treated. However, a treatment that works relatively well, especially for the older generation, is cognitive rehabilitation, an intervention that is often used for patients with traumatic brain injury. The core of cognitive rehabilitation is to teach hoarding patients to categorize, plan, and solve problems. They are taught to go through each item one at a time and to decide what to keep and what to discard. Over time, patients learn that they can tolerate the distress of discarding. Cognitive rehabilitation showed a 40% reduction in hoarding symptoms, the improvements having been maintained at a follow-up 6 months later. Students, before we move on with our lesson, let me tell you about what to expect in your next lesson, Lesson 5 for your course diploma in psychology. The next lesson will address schizophrenia, schizophreniform disorder, and schizoaffective disorder. We will go through the key factors that define these disorders and investigate what the research says about how such disorders develop. These disorders usually include periods of hallucinations, delusions, or depersonalization, and such symptoms take the patients away from their realities or that which is happening in real life at a specific time. I'm very excited to present this lesson to you. You are welcome to watch the movie A Beautiful Mind in preparation for this lesson. The lead actor in this movie is Russell Crowe. Let us now move on to discuss trichotillomania. Trichotillomania, also sometimes referred to as trick, is another disorder that falls in the category of obsessive-compulsive disorders. Let us look into this disorder and learn why it's part of the obsessive-compulsive disorder clusters. Trichotillomania is a disorder characterized by not being able to resist the urges to pull out one's hair. Individuals who suffer from trichotillomania may pull out the hair on their heads or in other places, such as their eyebrows or eyelashes. This disorder is more common in teenagers and young adults. The general symptoms of trichotillomania include the following: repetitive pulling out of one's hair, leading to hair loss. The pulling of hair leads to significant distress or impairment. The individual has usually attempted to stop hair pulling before. The DSM-5 lists 5 criteria for trichotillomania, including A. Recurrent pulling out of one's hair, resulting in hair loss. B. Repeated attempts to decrease or stop hair pulling. C. The hair pulling causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The last 2 criteria for the diagnosis of trichotillomania, according to the DSM-5, include D. The hair pulling or hair loss is not attributable to another medical condition, such as a dermatological condition. And E. The hair pulling is not better explained by the symptoms of another mental disorder. What other features of trichotillomania support the diagnosis? Let us peruse the literature. In trichotillomania, hair pulling may be accompanied by a range of behaviors or rituals that involve hair. Thus, individuals may search for a certain type of hair to pull, such as having a certain texture or color, They may try to pull the hair or hairs in a specific way, for example, pulling the hair so that all the roots come out. Or they may visually examine or tactily or orally manipulate the hair after it's been pulled, such as rolling the hair between their fingers, pulling the strand between their teeth, biting the hair into pieces, or swallowing the hair. Hair pulling may be accompanied by various emotional states, such as being triggered by boredom, anxiety, or it may be preceded by tension, which may lead to feelings of gratification, pleasure, or a sense of relief when the hair is pulled out. Some individuals pull the hair with focused attention, and other individuals display more automatic behavior, pulling the hair without being fully aware of it. Patterns of hair loss are variable. Areas that are bold with hair loss are called alopecia. Areas of complete alopecia, as well as areas of thinned hair density, are common. When the scalp is involved, individuals tend to pull hair from their crown or parietal regions, and eyebrows and eyelashes may be completely absent. The majority of individuals with trichotillomania have one or more additional body-focused repetitive behaviors, including skin picking, nail biting, or lip chewing. What are the risk factors for developing the disorder? Evidence suggests that trichotillomania is highly heritable through genetics. The disorder is more common in individuals with OCD and their first-degree relatives than in the general population. Let us look at the functional consequences of suffering from trichotillomania. One of the consequences of trichotillomania is distress and social and occupational impairment. Irreversible damage to hair growth and hair quality may be present, and infrequent medical conditions include carpal tunnel syndrome, dental damage, trichophagia, which is swallowing of the hair, which may lead to anemia, abdominal pain, nausea, vomiting, bowel obstruction, and perforation. Trichotillomania is a complex disorder and has been proven to be treatable with 3 types of cognitive behavior therapy and some medications. The types of cognitive behavior therapy used to treat the disorder include habit reversal, awareness training, and stimulus control. The medication that is most effective and best tolerated is an amino acid called N-acetylcysteine, which influences glutamate transmission. Other medications do not seem to be effective for the treatment of trichotillomania. If the patient has a comorbid mental disorder, medication for such a disorder will be prescribed, but the most effective therapy for trich seems to be cognitive behavior therapy. Students, we are nearing the end of our lesson, but before we complete the lesson, there's one more disorder to discuss, including excoriation or skin picking disorder. Let us move on. Students, we are at the last part of our lesson, and we are going to discuss excoriation or skin picking disorder. Let me introduce you to the core elements of the disorder. Excoriation, a chronic skin picking disorder, is a mental illness that is related to OCD because it is characterized by repetitive picking of one's skin. Such picking behaviors lead to skin lesions, and it causes significant impairment and disruptions in the individual's life. Individuals may pick at healthy skin, minor skin irregularities, lesions, or scabs. If left untreated, this condition may last for years, with periods of remission that come and go. Individuals with this disorder often spend a lot of time on their picking behavior. Skin picking is a body-focused repetitive behavior that typically starts during adolescence. Excoriation affects approximately 1.4% of the American population and is more often experienced by females than males. The DSM-5 lists 5 criteria for excoriation to be diagnosed in a patient. The first 2 criteria include that recurrent skin picking resulting in skin lesions has been present, and B, there has been repeated attempts to decrease or stop skin picking, and C, the skin picking causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The final 2 criteria as listed by the DSM-5 for skin picking disorder or excoriation include D, the skin picking is not attributable to the physiological effects of a substance or another medical condition. E, the skin picking is not better explained by symptoms of another mental disorder. What are the associated features that support the diagnosis of skin picking disorder? Skin picking may be accompanied by a range of behaviors or rituals that involve the skin or scabs. Hence, the individuals may search for a particular kind of scab to pull and they may examine, play with, or swallow the skin after it has been pulled. Skin picking is associated with various emotional states. The disorder may be triggered by feelings of boredom or anxiety, and it may be preceded by an increased sense of tension. A sense of gratification, pleasure, or relief when the scab has been picked may be experienced. Some individuals engage in skin picking that is more focused, whereas others engage in more automatic picking, and many may have a mix of both behavioral styles. Excoriation usually has an early onset during adolescence, commonly coinciding with or following the onset of puberty. A dermatological condition such as acne can be a trigger for the disorder to develop, and the sites of skin picking may vary over time. The usual cause is chronic, with some waxing and waning of symptoms if the disorder is left untreated. Excoriation is associated with the stress and social and occupational impairment, with the majority of individuals spending at least 1 hour per day picking their skin. Also, individuals spend time thinking about picking, and they may attempt to resist the urges to pick. Many individuals with excoriation report that they avoid social gatherings or going out in public, most likely because of the lesions on their skin. Excoriation patients have also reported that the disorder interferes with their work on at least a daily or weekly basis. Students have reported that they have missed school or time to study due to suffering from excoriation. The medical complications of skin picking include tissue damage, scarring, and infection, which can be life-threatening. Excoriation often requires antibiotic treatments for infections, and on occasion, it may require surgery. Skin picking is often accompanied by one or more mental disorders. These include OCD, trichotillomania, and/or depression. Repetitive body-focused symptoms other than skin picking and hair pulling may also occur, such as nail biting. Students, we have covered a lot of material today, and we are nearing the end of our lesson. Before we conclude this lesson, let us peruse the treatment strategies for excoriation. As with several of the other obsessive-compulsive disorders, excoriation is treated with cognitive behavior therapy and medication. Medications used for depression, such as SSRIs or SNRIs, are usually prescribed together with cognitive behavior therapy to assist the patient with understanding how their thoughts and behavior patterns are related to reducing repetitive behaviors. Individuals learn ways in which they can change their thoughts so that they can resist the urges to pick at their skin and avoid giving in to the compulsion of picking at their skin. Students, you have just completed Lesson 4 of Module 4 for your course diploma in psychology. Well done to you. I cannot wait to see you soon for Lesson 5, in which we'll address schizophrenia and other psychotic disorders.